Hello and welcome everyone. Thank you for joining us for the second webinar of the Africa AI Equality Toolbox, which today will explore system requirement and more precisely how requirement setting bridges vision and practice by ensuring that AI systems are aligned with cultural context, infrastructural realities, and human rights principles. And today we're going to use the Makerere Malaria Diagnosis Initiative as an example for community-centered and equity-driven design. So this case study is part of the African AI Inequality Toolbox, which builds upon the methodology of the Global AI Inequality Human Rights Toolbox, an initiative of Women at the Table in collaboration with the United Nations Office of the High Commissioner for Human Rights, OHCHR, and the African Toolbox, I must say, is a collaboration between the AI Inequality Initiative and the African Center for Technology Studies in Kenya, ACTS. So without further ado, we really need to kind of speak about the context and to set the stage. We all know that AI deployments in African contexts often fail when requirements are defined externally without understanding local realities. And so system requirements really act as the bridge between visionary goals and practical, equitable use. And today, more particularly, we focus on how defining system requirements can embed human rights, manage trade-offs, and ensure that technology serves and not exploits communities. So to briefly introduce the Makerere case study, and we have here Dr. Rose Nakasi, who led it. So we'll hear more of her. From her. But broadly speaking, the case study responds to a problem, which is that malaria remains a critical health challenge in sub-Saharan Africa, where traditional diagnostic methods face significant barrier. The gold standard for malaria diagnosis, microscopic examination of blood smears, often requires trained technicians and well-equipped laboratories and resources that are often scarce in the region where malaria hits harder. So the Makerere AI Health Lab, led by Dr. Rose Nakasi, confronted this reality directly. In many rural areas across Uganda, the shortage of skilled technicians meant that communities faced delays in diagnosis, subjective interpretations that were prone to human error, and really limited accessibility to diagnostic services. And of course, time constraints because of overburdened facilities, which further compromised patient outcomes. So what is their innovation? Their innovation is a 3D printed smartphone adapter that connects to standard microscope eyepieces, which exemplifies how technical design can embody values of accessibility and sustainability. And this innovation addressed the lack of expensive, dedicated imaging equipment in resource-limited setting by transforming existing microscopes into digital imaging devices. So Dr. Nakasi, I'm really delighted to be in your presence. Thank you for your time. And we're really excited for all the insights that you'll share with us today about this really groundbreaking project. You are the leader of the Makerere Health Intelligence Lab. You're also the principal investigator for the DS-I Malaria project, specializing in AI and data science for health equity in low resource settings. So I would like to dive directly with a question. The Makerere initiative began not with a technical solution in search of a problem, but really with a deep understanding of health inequity. And I would really like to explore with you how the team defined the real problem and how the team composition made sure that it addressed it meaningfully. And so the team, from the case study that I've watched and which is available in the Africa AI Toolbox, the Makerere team refused to use externally available data sets and instead built their own through local partnerships, despite the significant ethical and bureaucratic challenges that we all may be aware of or not, and would love to hear from you on that. What does this decision reveal about how requirement setting can prioritize ethical rigor and contextualize relevance over convenience or speed?
Thank you very much, Amina, for having me to have this very important conversation on the utilization of artificial intelligence, especially in healthcare. From our perspective, because to be able to understand the challenge that was at hand and to make impact, especially in the healthcare system, And I'm glad that you've also mentioned about the burden of malaria, especially in the African context. By the time we were beginning this project, sometime back in 2015, I would say that we never had any publicly available data set that we could utilize that had been collected using a smartphone to be able to, generate insights on malaria diagnosis. But also the context in which most of these endemic diseases are. If you look at a disease such as malaria with high endemicity in the sub-Saharan Africa, context-wise, as we look at the mechanism of diagnosis, which is by the use of the microscope, but also wanting to leverage artificial intelligence as a technology on the other end. And how the main question to us was, how can we be able to leverage, especially the existing diagnosis infrastructure in Africa, and how can that be supported by the emerging technologies such as artificial intelligence? So context-wise, in our way of thinking was, can we be able to come up with a solution that is able to solve a very big healthy challenge, but doesn't pose a very big cost, when it comes to implementation? So our thinking was, we have these microscopes. There was already a study that was conducted in Ghana, which actually attributed to the fact that there are so many microscopes than they are actually trained experts in most of the highly endemic settings. So our criteria was, can we be able to leverage the context that, well, there are these microscopes, but then there are also smartphones on the market, even in highly endemic settings. So ours was to leverage on the existing infrastructure, but also take advantage of the emerging technologies of artificial intelligence to be able to support the diagnosis of some of these diseases. So our context was, how endemic is the disease? What are the key challenges around solving, especially the problems around diagnosis, which actually in many cases is the lack of enough expertise? And how can we then leverage and utilize artificial intelligence in the most efficient but cost-effective way so that we can be able to extend that solution to the highly endemic settings such as Uganda? So for us, it was more of, what does artificial intelligence going to support, especially in our context, which is already constrained by a lack of enough experts, which is constrained by enough resources, and how can it then come into support, and how can we utilize it in the most reliable and cost-effective manner? So that is why we had to come up with the idea that we came up with in leveraging technology, but in the most cost-effective manner that utilizes and integratable within the existing infrastructure that is available to us. The other consideration was actually the stakeholder consideration, because the first conversation we had when we went to the collaborating institution, which by then was the main referral hospital, Mulago, as we were having these conversations from the technical perspective, where we were thinking, okay, we can develop cool application that diagnoses malaria with a very high accuracy, but having this engagement with the stakeholder, who at the end of the day is the end user, we were able to get enlightened about what is that they really desire to see in terms of the usability of the tool, because at the end of the day, for them, what they would really preferred back then was something that would take away the fatigue, something that will help them support the identification of these parasites with a lot of ease, something that will not make a lot of strain, because first of all, they are not ICT experts. So we wanted to bring in a tool that they can easily use and, be able to integrate within their work routines, that is faster, but again, not hard to use. So that particular aspect of usability also came along as we now tried to start the processes of designing the tool, not just looking at how we would actually make the models perform way accurately, but also looking at other aspects that are keen and are of interest to the end users, which in the bigger case was how they were looking at the usability of the tool and how integratable it would be in the healthcare system and how would it disrupt their daily routine. So those were some of the aspects that we drew conclusions on, and we drew a keen interest in developing the tools that we developed.
Thank you so much. I think, Dr. Nakasi, that really also demonstrates how you've ensured that technical requirements is driven by community needs and also the local infrastructure constraints like connectivity, power, but also usability, as you've said. And so I know that the team balanced about 99% accuracy for single class detection. And as you said in the case study, 5-second interference time with requirements for smartphone compatibility, but also the 3D printed adapters. Can you perhaps tell us about how requirement setting processes help teams actually identify and navigate trade-offs between performance and practicality?
Yes, performance and practicality is one of the things that we had to juggle with as experts from our end. One of the key priorities was if we can be able to produce an application that can be able to detect a disease at 100%, that will be the end goal, the ultimate goal. But then getting back into the context, especially when you go back to the testing facilities, one of the key experiences that I want to share is at first we had this model that will perform very well while in an ad hoc kind of environment where we're testing entirely in our lab settings, not going out in the field and trying to see how the model really performs outside, the development environment. So one of the key aspects or key challenges that we faced was what would work in a lab environment when you take it in a totally different environment will actually be something different, or whatever outcome that would receive would be totally different. So the trade-offs is usually between what the expert really wants to see and what happens actually in the real world or in the real application environment where tools are going to be deployed. So then the trade-off, especially when you're looking at diagnosis, is that you have to pay a lot of keen interest in what that outcome or what the accuracy really means when it gets back to the deployment environment. So there was need to ascertain and understand and clearly stipulate and document the environment under which the models were developed, together with the environments under which they are going to be either tested or deployed, so that we have that coherence to match what accuracy is at development phase to what it is going to be at deployment end. Because an experience I would share here was, there was a time we're collecting data using a Samsung versioned kind of smartphone. And this is the data that we used for the training of the models. The moment we took that model to a setting where we had collected the data with another kind of phone, and I think in this case it was a techno phone, results were clearly a little bit different. So what then that means is that what environment that we utilize while developing the model, if it gets to be different from the environment when you're testing, it is going to be a totally different context. And as developers, we need to align ourselves as we're developing these models to understand the kind of environments under which these models will actually be deployed and how that is envisioned as we're developing and, developing the models, so that there is that alignment, or there are those updates that have to keep happening so that we have a standardized kind of training and testing environment. Or if not, then we need to update our models iteratively so that they match the new environments, if there happens to be new environments. And what I mean by environments could be the devices that are being used, the way the data is being collected, what features have been mentioned, all that needs to be incorporated at development level when we're developing these models, so that that information is well captured to create a very clear and updated environment, so that we have that set as a standard. But also in terms of trade-offs, we really want to know what is the priority. What are we prioritizing? So in healthcare, if you to prioritize, for example, in some cases, we have what we call multi-classification, where you're looking at both detection of parasites and white blood cells, which are totally different, features of interest that you want to be able to detect. So what is your priority as you're carrying out this, detection also matters. In some instances, whatever they want to really prioritize is, has a parasite been detected? Probably that is the priority then. In some instances, what will be the priority is that you are clearly able to map out by what level of accuracy the model has been able to look at each and every parasite or whatever particle or object that you want to be able to detect within that model. So then it is always good as we're developing these models to know at the end goal, what is the priority that we want to achieve. And probably that will be able to identify or inform you about what trade-offs you need to take when you're collecting the data, when you're designing the models, and when you're deploying the models, so that that always comes up. There are also diverse perspectives that we have, because diverse perspectives will be that a perspective in the African setting could be totally different from a perspective in another setting. A perspective on a given kind of feature of interest that I'm interested in, I could be able to pay more attention to it than I would pay attention to another either object of interest within the same data set. So then that gets us to understand, okay, what would be these diverse perspectives, and in the development or in the design of these tools, have those different perspectives being incorporated. With malaria, it could be something that is, very easy to know that, okay, a man and female, woman and man, female and male, they are all equal when we're looking at the way the parasites present themselves. But in other applications where these could actually create diverse, or they could bring different insights during the development phases, could be something that we need to pay attention to, so that as we're making the trade-off or trade-off decision that we're going to take while developing the models, have those perspectives either been incorporated, because there is a need for them to be incorporated. If they are not incorporated, then we shall, get results otherwise, or they will be informing us of something totally different. And I think that's where the bias comes in, because at the end of the day, if those are not either captured or incorporated and integrated, then at the end insights that we might receive from such an application could be a trade-off that would go a wrong way, or that would be misinforming or misdirecting in whatever insights the model has been able to take. So as we look at all these perspectives, we need to understand, again, that goes back to what is the priority, but also beyond the priority, how have we been able to incorporate the different perspectives before we make a trade-off decision for the solutions that we are creating. And I think that is very, very important. So that, again, goes back to a summary where I would say, have we been able to establish the clear goals that we want before we come up with a tool in terms of what it is going to do, the bigger picture, but also at development phase, we also need to know what is the bigger goal that I want to achieve. What is that clear goal that I want to achieve out of these models that I'm creating, or these solutions that I'm creating. And then it will ripple into setting the priorities and the different perspectives and whatever design criteria that would be needed as you're gathering these requirements before you even begin the processes of development.
Thank you so much. And I think this really covers some of the curiosities that I had for my next question, because as you've said, the choice to use smartphones and locally manufacturable 3D printed printed adapters was driven by contextual constraints, as you've explained. And I'm really curious in terms of how community engagement played a role in setting up the priorities in the beginning, but also the infrastructure limitations came across. And perhaps if you could give advice to teams who would like to, like, how best would it, what are the strategies that they could make or do or plan for to understand context and avoid assumptions, especially to identify and prioritize context-aware kind of requirements early on, as you've said?
Every conversation that you're having, if we are to incorporate users within every stage of the development, then it becomes a lot easier for us as we're developing, because I would go back to the question that you asked about some instances, parts of where these tools are developed for, they have limitations in terms of power, in terms of electricity, in terms of, some of the tools, but because of the expert to incorporate them within their work streams. So at first, the tools that we developed for diagnosis of malaria were those that would require someone to capture an image, then send it over the internet, and then a model is able to draw an inference to it, then send back the response. But while we were having conversations in some of the remote health clinics that we are collaborating with, there was no internet connectivity to be able to even, relay an image over the internet to wherever the model is stored locally so that the inference could be sent back. So context is usually what is the environment under which these tools are going to be deployed. Understanding it clearly, and then you develop the tools that are fit for that kind of environment. So for us, it was driven by the context, the infrastructure limitations within our ecosystem, the lack of enough resources to afford even just, having internet connectivity is an expense. For those that actually do have it, at some point, they don't even have enough money to be able to afford it. So can we be able to look at tools that can provide a solution even in the absence of such infrastructure? So it has been driven by such kind of realities that at first we never had, but in having conversations at the different health facilities that we're collaborating with, because initially we had collaboration in the urban city center health facility, which is the National Referral Hospital. They had internet connectivity, they had power supply, which was a little bit stable, at least to some extent. So it was easy for us to develop tools that could incorporate all that because the infrastructure was enabling. But then when it got to having now to go outside the urban centers to the rural parts of the country, where electricity is a problem, where internet connectivity is almost not there. And even if it's there, sometimes they can't afford it. So it becomes very informative that you really need to come up with tools that are fit for such a context. So we had to come up with offline detection tools that can run locally on a smartphone once if the model has already been installed on that smartphone. The other aspect is now how has these conversations by engaging different stakeholders helped us to understand context very well. Again, in some of the conversations that we had with the health facilities, we went with this mindset that what we were interested in was actually just to look at parasite detection, and that was all. But with the conversations that we had with the experts on ground, was that actually sometimes the slides have artifacts which sometimes present themselves as parasites. So it was apparent for us to look at another task of identifying artifacts to improve the accuracy. You know, that for them, one of the big challenges they have is to be able to manually determine parasitemia, where they have to manually count the pathogens within the blood smear, and then also go further ahead to manually count the white blood cells, and then be able to determine parasitemia. So for them, that was again another big task. So away from just identifying parasites, it became apparent that what is also part of what they really need is to be able to come up with a tool that can not only just identify parasites, but also go further to detect for them, to do quantification for parasitemia. So most of whatever improvements actually we've been able to accomplish within this ocular tool was usually informed by what feedback we used to receive from the experts at the different healthy facilities. And that has shaped, including actually the development of the 3D printable adapter. The first design, and if you look at the iterations of those designs, they have always been informed by the feedback that we receive from experts on what kind of tool they would really feel comfortable using, rather than, you know, putting all the technical complexities on it, but just focus on how can I be able to insert a slot in a smartphone with a lot of ease without having to, you know, recollect the apparatus over and over again. So all that feedback has been very important for us because we have incorporated user-centered feedback through our user-centered designs as we're developing these tools. So it has been very, very important and critical to informing the iterations of improvements that we've received and been working on over time to improve the application.
Thank you so much. This also really reminds me of the previous webinar where Dr. Salifu and Dr. Makerere also mentioned how really transformational it was for them to go to the farms and to speak to the farmers in Uganda and Nigeria, where they were able to set the priorities of whichever innovation of the innovations they were working on with them. And I can also imagine that these innovations are, as you've said as well, require multi-stakeholder engagements and are filled with bureaucratic hurdles in terms of getting approvals. And so I'm really curious about sort of the challenges that you faced, which is ethical and bureaucratic challenges in collecting representative data. And how can requirements in this instance really anticipate and plan for such governance and ethical hurdles early on in the design process? Because maybe some of them come up along the way, and do they create kind of delays in the innovation or delays in the process? And what was it like for you guys?
Yeah, most of them were iterative challenges. Because we are dealing with a multidisciplinary kind of environment. For us, there is already a public health domain on one end, then there is also an ICT domain on the other end, and then you're bringing them together. So that kind of multidisciplinary kind of research and work that we engaged in, it was an opportunity, but a challenge at first, that because medicine or health has its already set standards in which they look at ethics. And then there is this integration where we're now bringing ICTs or artificial intelligence to get integrated into an already set kind of, domain that already has ethical guidelines and how they look at ethics. And then the bigger question to them was, how are we even looking at ICT tools or AI tools getting integrated within the already set standards? This is not just about porting, okay, I'm just going to drive an AI tool and directly integrate it into the healthcare system and everything is set. Behind it were so many considerations. Behind it were not just to look at data to stay at the healthy facilities, but getting data from the healthy facilities to support the development of these tools. So how that data now leaves the set standards, because for them, the set standard is that data resides at the facilities and shouldn't leave, because whenever it leaves, it's going to create, a human subject ethical concern. So as you look at that data leaving the health facilities to whichever development platform it's going to be put, in itself is an ethical concern. So those are some of the hurdles, and the question, there weren't hurdles because these people never wanted us to use the data, but because of the very glaring, concerns that everyone should be able to understand that, what, you're using a device, and that device is, for example, if you're sending an image through an internet facility to go wherever it's going so that inference is provided, how is that information protected, And coming from the point that we don't have yet already developed ethical frameworks to guide how AI is getting integrated into the healthcare system became a very big challenge, because they didn't have where to turn to associate the approvals to the already existing standards. So for us, it was more of having us look at what is the bigger goal, how can we come together, but at the end of the day, how is whatever concern that has been highlighted from the medical standards, how are we navigating it, and what solutions are we creating to be able to say, okay, if there is an ethical concern around how data is shared, how should we then protect that data? So answering those quick questions in a way that is very informing and very comfortable and very, at the end of the day, protective of patients' privacy was some of the conversations that we had to engage in. So it required involvement with the stakeholders, both from the AI field, from the medical field, and getting together and saying, okay, if this data is going to leave point A to point B, what are some of, certain things that have to be put in place? For example, how are you making sure that patients' privacy is well protected? Put up mechanism A, B, C, D. Do anonymization, do personal, PIEs, so that personal identifying information is not put out there in the public, and that whatever data you're collecting is free from such concerns that would actually go back to compromising the privacy of the patient information. But even then, for us, what really worked for us more was having evidence-based showcases of the work, first of all, to get it appreciated. Because for us at first, even just to understand, for having the ethical review boards to approve, they really needed to understand, how does this work? What insights does it bring? What impact has it created? What solution is it solving? So it came from evidence-based, showing the impact of whatever we are doing, to again collaboratively through these stakeholder engagements and collaborations that we had, working with them alongside to understand that, okay, there is usually this concern. How are we navigating it? What solutions are we creating around it? And that has been, an iterative process. We're still learning, they're still learning as well, but we're trying to find, at the end of the day, how these tools are impacting the public health care. And I think that is now clear for us, because to both of us, because at the end of the day, we want to create solutions that are impactful, but impactful in a more ethical way. And so we're trying to navigate the ethical pathways to making sure that there are ethical guidelines in place, and we're working now collaboratively with the Ministry of Health in Uganda to be able to come up with those frameworks, and then to be able to have these guidelines that will guide in the long run. But at every stage of the way, trying to always answer the question, how is patient privacy being taken care of?
This is really extraordinary and really phenomenal. And I hope you can take it to many other countries on the African continent. And actually, this partnership-based data collection with local health facilities truly reflects a non-extractive method. And I guess I want to probe you on the lessons that we can draw about designing requirements that redistribute power rather than concentrate it.
Yeah, exactly. It is always, we believe that even if it is you, you wouldn't want someone just to come, pick the data, and then without having what is this data going to be used for? How impactful is it going to be in at the end of the day, these tools are developed, our kind of relationship, health facility collaborate, we're looking at are they looking at what solutions are they keen about? Because them in the loop, trying to guide us in what solutions they are interested in and how this is going to support them while they are doing the diagnosis. Rather than just being extractive, we've always drawn collaborations where in the different projects that we engage in, they have been collaborating with us, not just as partners where we're getting data, but as partners. And so it becomes having them part of the solution holistically, from the time you're ideating to the solution building to the validation, so that at the end of the day, someone is able to appreciate the solution rather than you just coming up with a solution and just bringing it to their table. So what has been a learning experience for us and how easy this has been was always to involve the experts or the communities that we're working with, to iteratively work with them, not at just a point of receiving data, but a point of going through the entire phase of the solution with them, along the way, collaborating with them and having them on board to the point of validating and demonstrating the solutions with them. And I think that is how we've been able to maneuver, the skepticism part of what most people have always called skepticism from the healthcare experts, because we believe if we involve them, then they become part of the solution rather than just consumers of the solution.
Yes, and actually, I mean, it's very clear that this 3D ocular innovation was designed to support healthcare workers as opposed to replacing them, which, with everything you've said, really reflects that it has maintained explainability, but also human oversight and the human in the loop. And to go back to system requirements, the question here is how can requirement setting ensure that AI respects professional expertise and reinforces human agency as opposed to displacing it?
Yeah, I've had actually that has been one of the biggest concerns, especially with the experts. Before we could even go to the healthy facilities, the moment you land like this with your application, one of the concerns from the experts was, these tools, I think they're here to just replace us. Do we even still have a job anyway? And I think that has been one of the challenges. But for us, I think how um, clearly, if you demonstrate an application that comes in to support rather than replace, has experts from the facilities, the conversation has already has been, if it has been taking mere determination, for example, because for it takes quite a time. Look, there is this application that can actually slash down your time from 1 hour to just 5 seconds. So that means that if you have been looking at over 1,000 patients in a day, can we be able to translate that in time that the application is going to solve? Because literally, if you look at the WHO guidelines currently, to be able to screen patients, experts are not allowed to view more than 30 patients. But in most of the healthy facilities down here, you'd find that for malaria, for example, which is highly endemic, you find over 1,000 patients with only one technician, or sometimes even without a technician, a microscopist for that case. So the conversation has always been, these tools are just augmenting your work. They are just supporting whatever you're doing to slash down the burden that you've been having so that they lift off the weight, and rather than actually replacing you. Because at the end of the day, confirmation of the results is never left in the hands of the application. Confirmation of the diagnosis, we have always explained that this should only be given by the expert at the healthy facility rather than by the application. So the application would just support the decision that is going to be taken by the experts rather than actually replacing it and becoming autonomous in whichever diagnosis processes that are being conducted. Actually, even in the development phases, as we're collecting the data, as we're developing the models, as we're going back to do the testing, there is always a human in the loop, because we believe that human oversight is very important, especially when it comes to sensitive domains such as health. You need to know that there is auditing at every point of development. From the data collection, we need to have a human oversight. At the development phase, whatever the model is producing, we need human oversight. We need to have them in the loop to provide a very, holistic solution. Even at the tail end where we providing the confirmation, there should be a human in the loop who is going to say, yes, actually what the application is giving is the right information. So that has always been something that we have always iterated around to provide these solutions. But also, we want to prioritize transparency and also the explainability bit, because we want to understand what the models are producing or whatever outputs the models are coming up with, and should be translatable to what the standards of health or medicine relate to. So that means that the experts in the field also need to be able to understand at whichever process of development, whatever the model is doing and whatever the model is outputting at the end of the day. So it is not that we want to have a situation where everything the model produces is gospel truth. No, we want to have that explained very well and understood within the medical or health domain standards, so that at the end of the day, whatever solution is being provided by the application can be justified by the expert to have confidence of the results that it's producing at the end of the day. Having experts actually has been transformative for us, because it has built that collaboration, because it gets easier to actually accept these tools when there is an understanding between the AI experts and the healthcare experts on the other end. Because if that collaboration is nowhere to be seen, then trust is lost. And at the end of the day, we can't adopt, because there isn't that kind of conversation, there isn't that kind of collaboration. So we always foster collaboration between these different diverse teams, and whatever they are bringing on table is actually, we think that it's the holistic solution, because we have expertise coming in from all these angles. And we believe that's the impactful way of looking at solutions, especially in an interdisciplinary kind of, approach that we are taking.
Thank you so much. And I'm really, really excited to also kind of share that your team at Makerere AI Health Lab is now expanding the framework to other diseases, cervical cancer and tuberculosis, and also integrating telehealth platforms. And to briefly reiterate, system requirements doesn't exist in isolation. System requirements, in fact, determine what becomes possible in deployments, who benefits, and whether systems can be sustained by communities themselves. And so to speak about the expansion or the scaling, how is that going? And how can requirement setting processes build in adaptability and expansion pathways from the start?
Yeah, for us, I believe we want to create a solution at the end of the day that is going to solve most of the pressing health challenges, not only malaria. And I think for the diseases that you've mentioned, when you look at diseases such as cancer, when you look at diseases such as tuberculosis, when you look at intestinal parasites, they are all diseases that pose a very huge public health concern. And not only in the sub-Saharan Africa, but you see like a disease such as cancer, it can be integratable even beyond the jurisdiction of Africa to other global settings. But also when you look at diseases such as malaria, which are locally concentrated within the sub-Saharan Africa, they are also prone, to importation. For example, if we get a case of malaria, it can't go in the USA, So it creates not only just a sub-Saharan Africa public health concern, but a global concern. So for us, that has been the motivation to the scale. How can we utilize this solution to not only just look at one disease in Uganda, but to look at a solution that can provide a solution to the endemicity of these diseases in the different parts of the world? That has been one of our motivating factors. And for whatever scaling opportunity that we receive, it has always been, can this solution be able to answer a given public health challenge? And so our team has been composed in such a way that it is not just about focusing on one disease, but it has been around what can the solution be able to support across the different public health challenges. And so that has always informed the scaling opportunity and the scaling approach that we utilize, and also the multidisciplinary kind of team that we have currently, because initially what we are concentrating on was a team from the AI experts and also the teams from the microscopy for malaria. Now we have to go beyond that and look at, okay, what are the challenges that pathologists are facing on the other end? What are the challenges? For example, if there is a scale up, can even go to ophthalmology, whatever scaling approach and task that we're looking at, it is always informed by one, what are the bigger public health challenges and how can we cover area? And that has also informed the strategies around the solutions that we're generating, the teams that we're creating, but above all, answering at the end of the day a question on the public, what public health concern are we trying to solve? And that has been one of the motivating factors behind.
Thank you so much. And sadly, we're coming to the end of the webinar, but I have one final question that I would really like to ask you, which is really both a reflection, but also an advice from you on how can system requirements be institutionalized so that other teams working on AI in Africa really define requirements, both following pathways that are technically sound and socially grounded.
Yeah. For us in Africa, it has been a way to appreciate artificial intelligence and its impact in healthcare system. It has always been a question on evidence. Can we be able to create evidence that we can stand tall on and say, yes, artificial intelligence is not only for the global north, but it can also be impactful in the global south. So our concern has always been, what are the challenges that we face? Because every time you go out, there is always a societal challenge, not only in health, actually, across the different domains. And so for us, what has been one of the motivating factors is, what is that challenge out there that we need to utilize artificial intelligence for to solve such a challenge? But also coming back to the context, community is very important, because you come up with a very cool application, but community would not appreciate it. It can't be adoptable, probably. It's very expensive. You know, it's something that they cannot do with. So it has always been one of the key considerations, I think, as we're gathering requirements for the AI tools before even we develop them, is to be able to understand the communities we are developing these tools for. What is the community? What is their need? And is this a fit for solution for them? And that actually then iterates through the processes of developing the solution with them in the loop, having them through the design processes, because that is where we're going to get user feedback that will improve the tool and make it fit for community or fit for context. So it all goes back to understanding the problem, have the community participate in the problem, and therefore that requires you to do iterations of stakeholder engagements to understand these requirements and develop the solutions alongside them. But also at the core, because as we develop solutions, there is need for an enabling governance environment. Because one of the hindrances to have these tools integratable, especially in the African context, has always been, we don't have policies, we don't have guidelines, we don't have frameworks that are guiding us to have these systems integrated, especially in a sensitive domain such as health. So as Africa, we need to be intentional about developing these governance frameworks, these ethical frameworks that are going to provide an enabling environment, so that as developers come up with these tools, they're integratable within the existing system, so that it becomes seamless but impactful at the end of that day. At the end of the day, we provide, especially in health, the mandate is to always come up with better patient outcomes. So as we're gathering requirements, at the end of the day, we need to put it at the bottom of our hearts that whatever solution I'm providing, how is it bettering the outcomes for the patients? And so that always should be the motivating factor to inspire whatever idea, whatever solution we are thinking about, and in which measurable quantities are we looking at it in providing those better patient outcomes. So with that evidence, I think it will be the propelling factor to developing interest, to better adoption, especially within the communities, but again, to the governance authorities who are to give us an enabling environment to have these integratable. I think that's it.
Thank you so much, Dr. Nakasi, for really, really critical insights on how you've built the 3D printed smartphone adapter for malaria diagnosis, but also how system requirements has been an essential step for making it work efficiently in the development process. And I personally have many, many takeaways from what you've shared with us today, and takeaways to emphasize. First, that requirement setting is not only technical, but it's ethical, participatory, and contextual. You've also mentioned that trade-offs range between speed, scale, accuracy, and that they must be made consciously and transparently, and that we must document the rationale for all these trade-offs. The third one is human rights framework really ensure that AI systems serve people, not just technology agendas. And that, as you've said quite very eloquently, that partnership model really redistribute power and ensure sustainability, and speaking to the communities, going to the hospital, going to the health facilities is very important. And the fourth one is that context-aware design requires deep engagement with infrastructural realities, which really made the 3D printed adapter a reality. And we mustn't make assumptions about connectivity, about power, about literacy, and that local manufacturing is really also key. So thank you so much to everyone who's joined us. The hour went by so quickly. I wish we had more time with Dr. Nakasi, but please join us for the next webinar, which is on October 20th, and which will focus on the third stage, which is data discovery. And this will offer a deep dive into the essential questions of data discovery. And the case study that we'll focus on will be on the requirement needed for building effective TFGBV prevention data sets that include African languages. Dr. Nakasi, thank you again so much for your time and your generosity. And I wish you a wonderful afternoon. And for everyone who's joined us, don't hesitate to check the links that I've shared on the chat. If you have any questions or would like to explore the African Toolbox further, please do. It's an exciting product and project and document. Have a wonderful afternoon. Bye-bye.
Yeah.
Thank you. Bye-bye.